We are very pleased as well to have Dr. Martin Belkin here, who is the medical director of the MS Center at the Michigan Institute for Neurological Disorders. This is one of the largest private MS centers in the country, and it has certainly left a strong mark in the state of Michigan for their work in MS care. In addition to his extensive experience as the primary and sub-investigator for clinical trials in MS, he is also known nationally as an excellent speaker on the topic of MS. He is actively involved in educating medical students and residents in the field of neurology. He serves as residency program director for Ascension Macomb Oakland Neurology's residency program. He is also a clinical assistant professor at Michigan State University's College of Osteopathic Medicine, as well as Oakland University William Beaumont School of Medicine. And he was our 2019 Yoga Moves MS Leadership Award recipient. Martin's presentation will be on recent advances in MS therapeutics and clinical research. And Dr. Belkin, thank you for being here.
Thank you. I think the slide should pop up. Yeah, certainly want to thank Mindy and Dr. Voci for inviting me to speak today and really giving me the privilege of talking about recent advances in MS therapies, clinical research. Our center has always been at the forefront of research started by my mentor, Dr. Howard Rossman, and we've been able to continue it and really take it to the next level. So we're going to talk, there's a lot of information. I have about 15 minutes to talk, and it's about 2 hours worth of information, so I apologize. I'm going to talk quickly. I'm happy to try to answer questions after the fact so we can keep the program moving or even at a later time. So we'll just get going. So next slide. So real quick to kind of talk about the classification of MS. Many of you, I'm sure, have seen this slide in some iteration, but just real briefly, it's classified. There's clinically isolated syndrome. That's where patients may have one clinical event in an MRI with at least 2 lesions that are typical of MS lesions, but they haven't had any other clinical episodes. Majority of patients, though, about 85%, have relapsing remitting multiple sclerosis. That's characterized by relapses with complete or incomplete improvement, followed at some point at a later time with another relapse, and so on and so forth. However, those patients who are untreated or certainly undertreated, often eventually or majority somewhere down the road will enter what's called secondary progressive MS. And that's characterized by slow, steady progression and may still be active and characterized as active SPMS, where they still have relapses, although continue to have progression in between, or non-active SPMS, where it's generally just slow, steady progression, which may plateau at a certain point, but otherwise continues to progress. And then about 10% of patients are what are considered primary progressive MS, which is essentially from symptom onset or disease onset. There's generally a slow, steady progression. So next slide. Again, another slide that many of you have seen in some way, shape, or form, but I just wanted to highlight a couple things. So one, we know there's this subclinical or preclinical activity where if you were to get an MRI on someone who ultimately was diagnosed with MS, you would actually see typical MS lesions until they cross a threshold and have that first clinical event. And then they go on to that relapse or remitting type phase in most cases. I mean, again, in those who are undertreated or not treated at all, eventually develop a more progressive phase. And you see that purple line, they develop that more, that ongoing clinical disability. And as they develop more clinical disability, we know that there's less inflammation going on. And we believe it's more of a neurodegenerative disorder at that point. And that's shown by that orange line. And then that light blue line that you see declining is talking about brain volume and brain atrophy. And as you've heard just a bit ago, we know that patients with MS brains atrophy at a greater rate than normal controls. And that actually, there's more evidence that starts at the time of diagnosis. And so we need treatments, we need therapies that are going to slow brain atrophy, if not bring it back to physiologic levels, the same as normal controls. And so, so that's going to be critical, and we're going to talk more about that as we go forward. So next slide. So here's a slide talking a few different factors. So one is neurological reserve. And what we do know is your brain has the ability to compensate. So when damage is done to your brain, and such as the lesions that we see with MS, your brain can compensate. So you don't actually have symptoms, you don't develop disability progression until you lose that reserve. And once you lose that reserve, and you lose that reserve essentially from atrophy of the brain, you cross that threshold of losing enough neurons, enough brain cells, enough brain atrophy, where now you start having more symptoms. Now you start having progression of your disease and disability progression. we've always thought of MS as a white matter disease, white matter being those areas of the brain filled with myelin, again, talking about the covering of the neurons, the myelin. But what we've learned in recent years is that it's largely also a gray matter disease. And gray matter is really tough to identify. You can't see gray matter damage on routine imaging. It's hard to assess. And we know that that actually begins at the time of diagnosis. And so what we've learned is that patients need to be treated early and they need to be treated aggressively. So we can preserve white matter, but even as important, preserve that gray matter. And then healthy, oh no, not ready, back. And then we know that lifestyle is definitely, no question, plays a role. And we'll talk a little bit about that. So diet and nutrition, diet and inflammation, so much we need to learn, but we know there's a correlation between diet and inflammation, and having a healthy lifestyle, exercise, movement, mindfulness are going to be extremely important in how someone does with MS. And then comorbidities. We know that patients with high blood pressure, diabetes, high cholesterol, and if that leads to vascular disease, those patients don't do as well. That'll factor into brain reserve and reducing your neurological reserve. So controlling all those comorbidities is going to be critical for a patient with MS. Next slide. So that brings us to recently approved therapies. And you know, it's amazing what's happened in the last 15 years in terms of MS therapeutics. Basically in 2006, natalizumab was approved, which is our 5th therapy, and it was a tremendous addition and still one of our most effective therapies. But now we have over 20 therapies. And so we can really tailor treatment to an individual patient, to their lifestyle, to their risk tolerance. So many factors go into that decision making. And so I'm going to highlight the most recently approved therapies. I'm going to talk really quickly. There's so much data in each one, and I'm just going to highlight a little bit of data on each therapy. And then we'll get into some emerging therapies. So we're going to talk about Mavenclad or cladribine, then 2 medications that are in a class called S1P receptor modulators, Mayzent or siponimod, Zeposia, which is ozanimod. We're going to talk about Vumerity, which is diroximel fumarate, and then Kesimpta, which is the latest approved treatment, which just was approved recently, called ofatumumab. Next slide. So the first therapy we're going to talk about is Mavenclad or cladribine. This is really unique because it's a non-continuous therapy. It's called a short course oral therapy. And to take a step back. So as you know, as I think you've just heard, MS is an autoimmune disorder. Your immune cells, these inflammatory cells called lymphocytes, B and T cells, are programmed they have memory to attack myelin. So they get into the area of the brain and spinal cord and they cause inflammation. They attack myelin and lead to the damage in terms of MS. And so Mavenclad is an oral therapy, but it's unique in the sense that it's weight-based dosing. So patients get 4 to 5 days of therapy. A month later, another 4 to 5 days. They're done for a year. And then year 2, they get another 4 or 5 days. And a month later, again, finish off another 4 to 5 days of therapy. And then they're done and they're just monitored. And the theory is they're reducing those B and T cells. And again, those B and T cells have memory. And it's thought that possibly by knocking down those B and T cells, when they repopulate, they no longer have memory to attack myelin. And that may play into the beneficial effect of this therapy. And so really unique drug, really beneficial, highly effective. And some of the clinical trial data I just want to highlight. So this was a trial done compared to placebo. And so one of the primary endpoints was annualized relapse rate. So the chance of having a relapse, it was reduced 58% compared to placebo. So dramatic reduction in relapse rate compared to placebo. The MRI, just want to highlight one of the MRI factors, so T1 GAD enhancing lesions. So the T1 lesions, those are the lesions that take up contrast. So that tells us that's active inflammation. So 86% fewer active inflammatory lesions on MRI compared to placebo. Then they also showed, again, what's going to be critically important is disability progression. So 33% reduction in the risk of 3-month confirmed disability progression. So clearly slows disability progression. So highly effective therapy, really unique in terms of dosing and mechanism of action. Next, we're going to talk about S1P receptor modulators. So this is a group, we have 3 of them, but we're going to focus on the 2 most recently approved. The first will be Mayzent, but what they do is those B and T cells, those lymphocytes, they sequester them, they keep them in the lymph nodes so they can't get out. So if they can't get out, they're not going to be able to enter the brain and spinal cord to cause that inflammation. And so Mayzent is a once-a-day oral medication, very well-tolerated medication. And this, again, was compared to placebo and 55% relapse rate reduction. So dramatic reduction in relapse rate, again, compared to placebo, showed benefit in terms of slowing disability progression, 26%. And I wanted to bring up this they did look at SDMT score. SDMT is called a symbol digit modality test, and it's a test that can be done in the office setting. It's a 90-second test. You're matching numbers to symbols, and it's been well validated in terms of looking at cognition, and particularly cognitive processing speed. And so what Mason was able to show is they can slow the worsening of that SDMT score. And so obviously that's telling us potentially slowing any potential cognitive dysfunction or cognitive slowing, which obviously is going to be critical for any patient with MS. Next is the other S1P receptor modulator, Zeposia or ozanimod. Again, want to highlight a little bit of data. Again, a lot more data for all of these therapies that we could talk about another time with a lot more information, but this was a trial compared to Avonex. So keeping in mind, this was not compared to placebo. This was compared to a medication, interferon beta 1A, a once a week injectable medication that many patients have been on for years and have done very well with. So it was compared to patients on that therapy. And you see, compared to patients on Avonex, a 48% reduction in relapse rate in a trial, the first trial, which was a 1-year trial, and a 38% in the Radiance trial, which was a 2-year trial. So significant reduction in relapses compared to patients who were on an effective therapy. I also want to highlight, they have very good data, although it's considered exploratory and nominal endpoints in terms of brain atrophy. And we're talking about really the ultimate goal of all our therapies is really to preserve the brain. We want to preserve the brain. That's going to ultimately allow patients to do well long-term. And so they showed fantastic data in terms of slowing or significantly slowing brain atrophy. And here is just looking at the whole brain volume loss. And you see significant reduction in both trials of reducing brain volume loss. But they did also subdivide it into what's called cortical atrophy and thalamic atrophy. And really thalamic atrophy is going to be quite important because that's been really well correlated to disability progression and cognition. And they showed very good data, significant data in terms of slowing that thalamic and overall brain atrophy. And we're going to get a little bit more into brain atrophy as coming up in later slides. Next. So the other recently approved, or another recently approved therapy is Fumarate or diroximel fumarate. Now, diroximel fumarate is the same active metabolite. The active metabolite is called monomethylfumarate. It's a medication that many of you may be on and familiar with called Tecfidera, which is dimethylfumarate. So very effective drug. We've now had it for several years. A lot of patients have been started on this medication and maintained and done outstanding. One limitation of this medication, though, is for many people, they have side effects, primarily GI symptoms, and that can be a limiting factor and really prevent them from being able to successfully stay on this medication. So this actually was able to reduce the number of, days with GI symptoms by 46%. So much better tolerated medication than Tecfidera, and really so patients who would be appropriate patients for Tecfidera or dimethylfumarate or are on it and having GI symptoms, really a better option to go on just from a tolerability standpoint, give patients a much greater likelihood of being successful in this therapy. Now, in terms of data, this is data derived from the initial trials with Tecfidera, dimethylfumarate, 49% relative risk reduction in the proportion of patients that relapsed over 2 years. So again, dramatic reduction in patients who have relapses over a period of 2 years. And then finally, I want to talk about the most recently approved medication, Kesimpta or ofatumumab. This is an anti-CD20 B-cell depleting therapy. So we talked about part of the pathology in MS are B cells and T cells. And B cells and T cells, they work together to interact to then go and attack myelin and cause the inflammation and demyelination that occurs. And so by depleting these B cells, we know that we can have a dramatic effect in terms of reducing inflammation, reducing disability progression, reducing MRI activity in patients with MS. So a highly effective therapy, aggressive therapy. And so this is the latest addition in ofatumumab. It's actually a subcutaneous injection. There's a loading phase, but then it's ultimately once a month. It's administered by patients at home. So that can certainly be a benefit for some patients. But if you want to look at the data, we'll highlight it real quickly. So this was actually compared to teriflunomide. Teriflunomide is an oral medication, very widely used. Again, a lot of patients do very well on it. But compared to teriflunomide, that relapse rate reduction, you can see in 2 different trials, 51 and 59% reduction sequentially or respectively. So really positive effect on that inflammation. And so really great addition in terms of treating MS patients. And then it showed a 34% reduction in confirmed disability progression versus teriflunomide. So again, slowing disability progression. But I think really what we'd want to highlight is the effect on MRI. And if you see those GAD-enhancing lesions, those lesions that take up contrast, tell us there's active inflammation going on, almost suppression of those GAD-enhancing lesions for patients on patients on ofatumumab, compared to patients who are on an effective therapy that's effective for many people. Next slide. So that brings us to emerging therapy. So again, we have over 20 approved therapies, great for patients with MS, but we still ultimately need more options and really to be able to tailor treatment to patients really on an individual basis. And where research is going in terms of disease-modifying therapies, there's going to be several trials starting, and our clinic has been privileged to be involved in these trials as well. Are called BTK inhibitors, or Bruton's tyrosine kinase inhibitors, and they're involved again in B cell development. And so they may reduce inflammation, they may reduce neuronal cell damage. And I think what's exciting, or potentially exciting for this class of therapies, is it may be effective for both relapsing as well as progressive forms of MS. Obviously, we have still a great need to help patients with progressive forms of MS. And so this class of therapies, we're hopeful will show benefit in progressive forms of MS. The trials, again, we still have a ways to go, but we're excited to be part of these trials and helping patients get access to this medication. Next. So we talked about disease-modifying therapies, but I think possibly right now we have so many great therapies. So the unmet need is, how do we repair myelin? How do we repair damage that was previously done? And so there is work, there is research ongoing in terms of repair therapies. And again, our clinic has been privileged to be part of pretty much all of these trials. And the question is really, one is ultimately, do they work? And if they cause or lead to remyelination, does that lead to functional improvement? And so obviously we don't have data yet, but these phase 2 trials are completing. And the first is something that affects what's called RGMA protein, or repulsive guidance molecular membrane A protein, more than you need to know. But basically what this does is this protein will inhibit cell repair. And so by using what's called a monoclonal antibody, it'll target this protein, potentially allowing for remyelination or repair. And so really exciting, and we're excited to get some data and hopefully move on to phase 3 trials and see if ultimately this can be approved to help patients with MS. And next slide. A second one, which we're also involved with, is a phase 2 trial that's finishing called AntiLungo. And this is another it's an IV formulation, IV therapy that has a potential to allow the cells that make myelin, called oligodendrocytes, allow them to turn on, allow them to actually produce myelin once again. And again, very exciting that we have this potential agent. Again, we have to find out, will it truly do what we hope it does? Who is it helpful for? Will it lead to functional improvement? But the fact that we have these agents and the science is there behind it, that they can actually lead to myelination, I think is extremely exciting. Next slide. And then there's future trial agents. There's been some really early research on something called gold nanocrystals. And these gold nanocrystals, what they can do is they work on the cellular metabolism. And so they can improve the metabolism of those cells that make myelin, called oligodendrocytes. And by doing so, they can allow it to actually turn on again and make myelin. In order to do that, it takes so much cellular energy. And so the cells just don't have that capability. So these gold nanocrystals can improve metabolism and allow myelin repair. Again, this is really early, but again, just showing that the research is heading in that direction. And the second one you see here, called an S1P4 receptor antagonist, this is actually a trial that we'll be involved with as well. That's going to be an potential for oral repair. So instead of an IV therapy, this will be an oral therapy. And the S1P4 receptor, by blocking that receptor, again, you can allow those oligodendrocytes, those cells that make myelin, to turn on and again start myelin repair. And then we talked a lot about, and you've heard earlier today, about other factors, not just medication. So diet and inflammation. We know that diet and inflammation, there's a correlation there. Foods that you eat can cause inflammation. What we don't really have, we don't have large studies telling us which diet is really the best for MS, or is there a specific diet or specific food. I think most of us believe that processed foods, sugar, certainly contribute to inflammation, but we need more research. So we know that diet is going to be is a big factor in inflammation, and we just need more research along that front. And then the gut microbiome, so a hot topic. not just for MS, a lot of neurodegenerative disorders. And we know that there's a difference in the makeup of the gut bacteria in patients with MS. And I'm going to show a slide of a poster that was just presented at an international meeting, ECTRIMS. But it's different in MS patients than healthy controls. And so can you correct that gut microbiome? And will that have a positive effect in the long run? And then antioxidant agents, alpha lipoic acid, it has a potential to reduce brain atrophy. And I'm not putting this on there at telling people to go start alpha lipoic acid, but showing that there's research in things other than just standard pharmaceuticals that can be used in conjunction with treatments we have to really help patients. So it's not going to be a single agent for everyone. It's almost going to be almost in a sense, disciplinary approach from different avenues to try to help patients with MS in the future. And then we need emerging MRI technologies. You've heard about brain atrophy, and really ultimately the goal is to preserve the brain, but how do we measure brain atrophy? And standard MRI really doesn't do it. We have MRI techniques, software that are used to look at brain atrophy, but there's so many variables that really affect the usefulness of it clinically, so you're really not able to use those to make clinical decisions. And so you need MRI technology advancements to really look at brain atrophy. And I'll show a slide of a poster also that was presented that our clinic was involved with, looking at artificial intelligence, looking at the thalamic atrophy specifically. So we'll just finish up these next couple slides. So this next slide, again, was talking about the gut microbiome. Basically, real simple, it was a poster presented showing that the microbial diversity in MS patients is different than healthy control. So there's a different makeup of the bacteria in the gut of MS patients. And ultimately, will that lead to therapeutics that can alter the gut microbiome that will have an effect on inflammation and neurodegeneration? And last slide. And this was, again, the poster looking at thalamic atrophy measurements using just routine clinical MRIs. So nothing fancy, just the MRIs you get every day, but you can, with artificial intelligence, this was developed by Dr. Zavadinoff in Buffalo. And so we were privileged to be asked to be part of this group to use regular MRI and his software that he's developing for artificial intelligence to actually measure brain atrophy in thalamus. And he showed that this may be truly feasible. And again, hoping this eventually becomes validated and somewhere down the road part of routine imaging studies, so we can really follow MS patients to a much more to a much finer degree and really tailor treatment more specifically and follow how they're doing. So and then I think just a summary slide. So really fast, we covered a lot in a very short period of time, but we talked about the recently approved therapies, which is just great additions. It just allows us to really tailor treatment and really make sure patients are treated early and aggressively. We talked about emerging therapies. We talked about the potential ability to repair myelin. We talked about, some agents that may offer some neuroprotection. Nutrition is going to be a key in patients with MS, controlling other risk factors, diabetes, vascular disease, hypertension, not smoking, and then altering the gut microbiome. And then ultimately the need for these more advanced imaging techniques so we can really look at brain atrophy and make sure patients are being treated appropriately and effectively. And so that's it. I don't know if we have time to take questions, but I'm happy to try to answer them on the side, or certainly they can get them to me at a later time.
Yeah, Dr. Buck, I think if you can maybe answer some of the questions in the chat box, that would be good, because we are running a bit behind.
Yes. So right now, I see a question, can someone take multiple therapies at one time? And the answer is right now, no. Some of that certainly has to do with insurance, but we also don't have data. But there's some thought that combination therapy may ultimately be part of the future to attack MS from different mechanisms at different times. And so, we would need data to support doing that, but there's some theories behind there that potentially medications that work quite differently and some that may have more of a protective mechanism may be helpful to use in conjunction with each other. So that may be the future, but certainly not right now. That's the only question I see.
Okay, well, Dr. Belkin, thank you. If any other questions come up, you can maybe answer them on the chat box. That would be helpful. Thank you for a lovely update. And thank you for your time. We really appreciate it. This is, again, a very nice collection of physicians we have speaking today, and Minnie, again, a great job of getting everyone together for this event.